All right, it is 12:30 and we can go ahead and get started. First, I would like to welcome everyone to our first event in our ongoing series to address maternal and infant health outcomes in our community. This series is presented by the Winnebago County Action Team and the Winnebago County Health Department. I am Jaleesa Bondurant, the community co-chair of the Winnebago County Action Team. The Winnebago County Action Team is a subcommittee of the Permanency Enhancement Project. This project is part of a collaborative effort between Northern Illinois University Department and the Department of Children and Family Services to improve permanency outcomes and address racial and ethnic disparities in the northern region of the state. At this time, I want to recognize all those who have helped plan, contribute, and supported the efforts necessary to push this agenda forward. There have been diligent efforts in the series to include individuals from various health systems, organizations, and community members. Our hope is to encourage our community to tell its stories so we can better educate our healthcare partners, empower all individuals to advocate for themselves and their loved ones, and work collaboratively to provide solutions. With that being said, let's get into the data presented by Winnebago County Health Department, Dr. Martell.
Thank you, Jalissa, and thank you for all of our participants on the call today, as well as those that will be viewing this via Facebook. So the purpose of today is really to kind of kick off this series with understanding the data in Winnebago County and relative to the state. So why should we be concerned about maternal morbidity, which is pregnancy complications and maternal mortality? These are two of the most sensitive indicators on the overall health status of a community. Unfortunately, maternal mortality has been increasing in the United States. It is 3 to 4 times higher than other developed nations. Health disparities persist in the United States, and pregnancy mortality is higher for Black women than white women. And those determinants are also impacted by the social determinants of health. It is not just healthcare that we're talking about. In Illinois, an average of 75 women die each year while pregnant or within the 1 year of their pregnancy. That's 1 death every 5 days. And I think the calendar really hits at home. If you were to think about April and 30 days, we would have had every 5 days, we would have had a death.
Okay,
Pregnancy-associated death. And we're going to talk about some terms here so that people can understand, because we often hear about this related to other conditions. So a pregnancy-associated death is death of a woman during the pregnancy or within 1 year of the end of the pregnancy from any cause. Then pregnancy-related deaths are death of a woman during pregnancy or within 1 year of the end of the pregnancy from a pregnancy complication. This could be a chain of events really that start during the pregnancy or are aggravated or made worse by a pregnancy of an unrelated condition. Things like hypertension or high blood pressure, preeclampsia, diabetes, sickle cell, hemorrhage, stroke. These might be pregnancy-related deaths. So pregnancy-related deaths. So those are those conditions that contribute or maybe exacerbated or gotten worse over a pregnancy. 1 in 3 women will die during their pregnancy. Of that, another 1 in 3 will die in the first 2 months postpartum, meaning 2 months after the birth of the baby. And 1 in 3 women died 2 or more months post-delivery of the infant. And here's an important take-home message and why this group has been working to address this issue. More than 4 out of 5, or 80%, were preventable. And here's another very sad fact that we need to address. Black women are most likely to die from those pregnancy-related causes. They are 3 times as likely as white women. So when we start thinking about maternal health, it's not an all or nothing. It's really a continuum of how we view and care for women who are of childbearing age. It starts with healthy moms. Remember those pregnancy-related conditions, things like diabetes and high blood pressure. If our moms are going into their pregnancy in the best state of health, we have a better chance of healthier outcomes. There might be minor complications along the way, but what we were trying to prevent is that severe morbidity and death, which is the mortality factor. So we really need to be addressing that continuum at the base of this triangle, which is how do we prepare, how do we help our community women to be as healthy as they possibly can be so that we can address the complications as they occur. I talked a little bit about those social determinants and disparities. I often hear we have great prenatal care systems in Winnebago County. We have 3 phenomenal healthcare systems that provide excellent levels of care. We have a perinatal center, but it's not pregnancy, and prenatal care is while important, is not sufficient. It's a mandatory condition, but it certainly is not the only one. We look at things like educational access and quality. What's our educational system in terms of accessing? What are the reading levels? What are ability of people to find work or graduate from high school to find gainful employment? We talked about that healthcare and quality of healthcare. Accessible healthcare, meaning you can get to it, may not always reflect quality of care. Is it the highest level of quality of care that we can get? Does every woman have equal access and more equitable access for our Black women who have higher risks? Neighborhoods and built environment. We live in a community that's environmentally fragile, as we know. Our housing stock may contain lead. There may be lead pipes providing water into our communities. Low-income housing may be substandard. There may not be adequate rooms or housing. Those are the things that we talk about in terms of our neighborhood and built environment. How much Section 8 housing do we have? Do we have affordable housing that's safe and secure for our families? Then we look at social and community context. This is that connectedness that we really struggled with throughout the 2 years of the pandemic. But more importantly, this is where things like structural and systemic racism occur, about how do women perceive their ability in the community to receive the level of care that they need, to be part of our ongoing fabric in our community. How do they feel that the community treats them? And then we have economic stability as another social determinant. You'll hear more about some, as questions come up about what is the living wage in our community? How hard is it for women to have gainful employment? What are childcare options for them? Do they have safe, affordable childcare if they need to work? All of these social determinants impact our maternal morbidity and mortality in our community. And then we talk about some risk factors impacting pregnancy outcome. I think the top 3 that people always ask about are things like smoking, obesity, and diabetes. And so I'm going to show you some information that's hot off the press. It is out of the county health rankings that ranks counties throughout the United States. It is part of the Robert Wood Johnson, the University of Wisconsin School of Public Health. But they look at adult smoking. The healthiest communities in the United States have adult smoking rates at 15%. Illinois is 15%. Here we are at Winnebago at 18%. And smoking, we know, is one of the contributing factors to low birth weight and preterm birth. Obesity. We often hear about, Winnebago County and the issues to address obesity in our community. Healthiest communities, about 30% of the population are obese. Illinois is at 32%, and here's one where we're at 30%. But again, it's certainly we would want to do better. And then we look at diabetes, which is one of the complicating factors if you talk about gestational or diabetes occurring during pregnancy, as well as overt or diabetes that occur type 2, which occurs later in adulthood, and type 1, which is the insulin dependent that occur younger in life. The healthiest communities in the United States have about 8% rate of diabetes in their community. Illinois is at 10%, and Winnebago County is at 11%. So we look at 3 kind of health behaviors or risk factors, and they term these as health behaviors, or these are modifiable risks, meaning we can do something about those risks. We can work to reduce our smoking. We can reduce our weight. We can address diabetes and get that under better management and care. So when we look at those 8 factors, again, we are really on an uphill battle to address those factors in our community. Another question that I'll talk about, we talk about adequacy of prenatal care utilization. It's really kind of I'm going to say more a fancy term per se. There are 2 factors that really influence that. We want women to enter prenatal care as soon as possible. So this factor looks at when was prenatal care started. So pregnancy months 1 and 2. This is often a time when women don't even know they're pregnant or may not even be sure that they're pregnant. Pregnancy months 3 to 4, 5 to 6. And we do have women that start in what we call the 3rd trimester, between 7 to 9 months. And then it looks at the total number of prenatal visits from the time that they start their care to the time of delivery. And it's based on the American College of Obstetrics and Gynecologists standards. And they put kind of some labels around this. They label it as inadequate if you have less than 50% of the anticipated visits based on when you entered care. Intermediate if you did 50 to 70% of visits. Adequate is 80 to 109%. And adequate plus is 110%. So we are really aiming for above 100. This is the curve we want to break. So when we start to look at, and I want people to understand, and I know this slide is kind of very small to read, is that it starts to look at how many visits should women be having at different times of entry into prenatal care. And when I talked earlier about Black women at higher risk for those medical complications, we would expect them to have higher rates of visits because they should be monitored more carefully throughout their pregnancy and have more visits with their providers. And so here's the data for us about average number of prenatal visits in Winnebago County. So what you look at is you see Asian women have the highest rate number of prenatal visits at 12. Black women are lower at 10.79, white at 12.32, and then 11.5 for more than one race. So once again, we expect the population, when we talk about equity issues, to have actually more visits, are actually having less than their counterparts in our community. So another indicator, when we talk about going into that pregnancy and time of delivery, one of the areas that we always look at is our C-section rates. And why are we concerned about C-section rates? Well, it may indicate that there's fetal distress, meaning that the baby is in danger of, either, suffering a poor outcome or the mother is suffering a poor outcome. It also is an indicator that there are greater risk for complications in that postpartum period, that time frame after the delivery of the infants. So this is based on our C-section rates from our 3 hospitals that do deliveries. And I want to point out here, we've got the Illinois rate is 261.66. I always say, let's round up to 262 for the ease of comparison. When we look at Swedish American at UW Health, they do about 294 per 1,000 deliveries. Mercy Health now is advocated, Javon Bay Riverside is approximately 310 per 1,000. But remember, they're also a perinatal center, so I'll kind of talk a little bit more about that. And OSF, St. Anthony Medical Center, is 331. But what you're seeing in our community is we have all 3 hospitals have higher rates of C-section than other areas of the state. So we really have to be mindful of, while C-sections may be medically necessary to care for individuals, it also puts our mothers at greater risk for postpartum or those complications after the delivery. So low birth weight, what do the numbers look like for that? So first of all, I want to make sure that everyone understands a low birth weight infant is defined as weighing less than 5.5 pounds or 2,500 grams or less. And so when you think about that, I often say to people, I challenge you to go into the grocery store and take a look at what a 5-pound chicken. It's small, it's tiny. This low birth weight percentage for our county is 9% as compared to 8% for Illinois. And again, top performers throughout the country where the women are the healthiest and have the healthiest outcomes as 6%. And so we have a 50% difference here in our low birth weight. And when I think about when you look at that, 5.5, pounds, that's a very small infant. And that makes it very hard for that in terms of recouping and losses at that point. So how does our low birth weight by race look for Winnebago County? So again, you look at, and this is kind of the graphic that helps you understand it, is that for our Asian women, it's 9%. For our Black moms, it's 15%. White is 7% and Hispanic is 7%. But when we get back to our rate for low birth weight for our Black mothers, the rate is over 2 times that of their white and Hispanic sisters. We have got to do a better job when it relates to these low birth weight infants because the complications these infants have are greater, and we must continue to work on that. So clearly, our disparities exist here. So preterm births, those are babies born too early. So we have low birth weight babies that are born too small, and then we have preterm births born too early. So when we look at it, Winnebago County is the blue line. So again, we're kind of paralleling the state, but we've had, again, decline from 2010 to 2013, but we've increased since 2016, while the rest of the state is remaining stable. So our women are at increased risk, again, for preterm or early deliveries and births. So here's another data point that we need to look at, which is teen birth rates. So we know complications occur in the earlier years of that. Again, when you think about that triangle, maternal health, a teenage body, a teenage time frame in terms of giving birth. So when we look at teen births, we're talking about individuals 15 to 19 years of age per 1,000 population of women who give at that age. So in Winnebago County, our teen birth rate is 27. And we look at, again, when you look at the breakdown, we see again that Black teen moms are at greater percentage. They have a higher teen birth rate than their counterparts and almost double that, again, triple that of the white population. So we really have to be thinking about what can we do differently. And when we go back to the social determinants, think about educational attainment, think about, economic stability. Those become critical assets if we are talking about building a healthy infrastructure for our moms. I put this up as breastfeeding breast is best because one of the issues that we know, breastfeeding supports both the postpartum rates, and I want to talk about the benefits for moms. It reduces the risk of high blood pressure, the type 2 diabetes that we talked about, ovarian cancer, and breast cancer. For babies, it reduces the risk of various infections. We talk about immunity passing to the infant before they can receive their vaccinations, and for other kinds of things like necrotizing enterocolitis, which is a very devastating intestinal condition where infants can suffer severe consequences, including death. Sudden infant death syndrome, type 1 diabetes, that's that early onset of childhood type, and obesity later in life. So when we looked at our obesity number, here's where we can begin to take a look at how can we do some upstream prevention. So there's benefits to both mom and baby with breastfeeding. So taking a look at some of our data from out of our own, hospital systems again, and this was done at a time when they were calculating out of Rockton Avenue. So exclusively breastfed about less than 50%. OSF St. Anthony was 67%, and UW Swedish American was 62%. This formula fed, exclusively formula fed percentage, about a third of the infants were exclusively formula fed. So they were not getting any benefit, and neither was the mom of breastfeeding. And again, when we get to any breastfeeding, our goal obviously is to increase our breastfeeding rates. You see that again, Mercy, at about 2/3 of the moms have any breastfeeding. We get a little higher at the OSF St. Anthony at 80, close to 80%. And then UW Health has one of the highest. And I'm going to put a plug in for my team from the Wic team there, because I know they do a lot of outreach and with the UW Health system to promote breastfeeding among Wic. But Overall, CDC also reported lower rates of breastfeeding among our Black moms, 68% as compared to 85% of white mothers. So we are showing those disparities and how can we improve the outcomes from our moms and babies. So why should maternal and child health in our Black community matter? Because poor health outcomes are preventable. It impacts the health of our entire community, and it represents the future of our community. So with that, I'm going to turn it back to Jalissa, who's going to moderate questions and answers throughout.
There we go. My apologies, forgot to unmute myself. Thank you, Dr. Martell, for walking us through the data walk. I still cannot believe the numbers. I have two people on the call that will be assisting me with questions. We have Catherine and Riva. I will reach out to either one of you to see if there's any current questions, and if not, then we can get into just some other general questions.
Do not see any questions coming on Facebook yet.
Okay. I don't think I've seen any in this space. So one of my questions that I have is, we know the data, what the data looks like now. Why did the health department find this important? And what was the health department's reaction once you came across some of these numbers?
Well, we've been working on this probably for 2 decades now. And when you look back at what we call our community health assessment and community health improvement plan, maternal and child health has been identified through consistently. We know, and what we're learning through is that the pandemic, while it caused some, I'm going to say some delays and pauses, it did not improve the numbers. It actually exacerbated the disparities. And we need to continue to work on this. As a health department, as I've said before, it's unacceptable. This is a concern for us as we look at how do we improve the health for our entire community. It starts with our mothers and our babies. And we have to really understand that we're building families as infrastructure. And so some of the work that we started, I'm going to say the last go around was part of the trauma informed, which really took a look at how did all 3 health priorities, maternal and child health, mental health, and violence, how were they connected? And so we began the trauma informed community work. And now we want to work more aggressively on isolating really the kind of and focusing on the maternal and child health, especially maternal health outcomes.
Awesome. Elsie, I see your hand. Oh, you're muted, Elsie.
Dr. Martell, is the school district helping in this cause any way that maybe I don't know that you might?
Well, I think that, the question was about school districts and how engaged are our school districts.
Yeah.
Well, I think part of we were doing work significantly before the pandemic. And I think, of course, we've all had to take a little bit of a pause, but we've got to re-engage with the community and our schools. It's not just a school issue, as you know, it's an entire community issue.
Yes.
As a community, as a member, whether you're, when I think about so many of our members will say, well, I'm not a mom. I'm a grandma now. My family's all grown up and gone. Why should it matter? And it should matter because this is our community infrastructure. If we are talking about being a vibrant community with a vital business sector and educational sector, we need to start building this now. And we need to invest in this group. So we will, again, engage schools to the, discussions about where we can improve those outcomes, where they can assist us. Again, oftentimes it's making sure that we have good referral connections.
Follow-up question. What methods or processes are out in the community to let people know of the services and the issues that we're talking about today?
Great question.
Well, I'm going to pitch this off to Cheryl as one of mine, as well as Shireen, who are both program leads for several of them. But I think, first of all, throughout various times, right? So we've had done We are part of the neighborhood initiatives now that are focusing on the 6 highest risk community areas in Rockford. We are part of that door-to-door walk around and created a flyer that, and again, we understand that the new generation does not look at flyers per se. So it's got, QR codes and connections to link them to various services. And I'm going to ask Cheryl to talk a little bit about Wic Outreach, which is the Women with Children Supplemental Nutrition, and then Shireen to talk about the maternal child early home visiting initiatives.
Thank you, Dr. Martell. Yes, definitely with our WIC program, we have our pregnant and parenting moms. And so we definitely encourage and provide information on breastfeeding as well as education on the importance of it. And we also understand that, every mom who may want to breastfeed may not be able to. And so we don't want anyone to ever feel discouraged. And so we can still, care for your child, and we encourage the prenatal visits, the postpartum visits for mom. And also we refer moms to services. So as the WIC participants or the WIC nutritionists are meeting with the moms, there are a series of questions that they ask for assessments. And so they can do referrals to the community as needed.
I know Cheryl mentioned the prenatal, and that's what I was thinking about the most. I just think the prenatal is vitally important in getting information out so that moms have access to the care that they need, so that they can begin engaging with their primary care physicians. Through the maternal infant early childhood home visiting program, we have about 5 home visiting programs, and we serve about 300 to 400 families within that network of providers that we have, home visiting agencies that we have. So in reference to Elsie's question of getting the word out, we try to do that through our home visitors. Most recently, we are having quarterly meetings with our home visitors so that we can get information to them and empower them with facts and figures, and representatives from the community that will provide them information that they can carry it on to the families that they serve. So that's just one of the ways that we're getting information out. And we have other things that are coming in the future. But again, I just think what we hit on a little bit earlier and what Cheryl mentioned with the prenatal care is vitally important with our moms, that they have access to healthcare.
And I think the follow up on that as well is, I always say it's our role in the community is to help each other, right? So I think that the connection between all of our community-based organizations and our faith-based organizations, we're also engaged. We often get calls or referrals. One of the clinics that we do operate here at the health department is the family planning clinic, where women can have a pregnancy test so that we can engage them in that discussion about early and ongoing prenatal care. Remember, going back to that earlier slide, the sooner I can get you into care, right? I want to make sure that I contain you and remain with you in care so that we can monitor your course of your pregnancy, and so we can hopefully impact the best outcomes possible.
Thank you for that. It definitely sounds like there's a lot of resources out there, and where the health department especially is doing a more increased effort in getting people connected in the community with these resources. One question that I also have is, how can women better advocate for themselves? It almost seems like part of the issue is getting them connected with the services or getting them connected with the doctor's appointments. But once at the doctor appointment, if there's issues, if there's complications, what resources are out there where moms and women can advocate for themselves better?
Well, I think, part of it is, first of all, enlist supportive individuals, right? I call it the buddy system. But I think more importantly, we've got programs like Better Birth Outcomes. I know these all have fancy names on them, but it's really like a case management advocate that can go over with you. What questions do you want to ask of your provider? What should you expect from your first visit so that when things don't go as planned, how can we reconnect you back in? I think that that's part of that WIC engagement as well as for the most at-risk women is to ask them, how did your prenatal visit go? Were the things, can we often hear they may not like that first visit with the provider. They may want to choose a new provider. How do we help engage them? But I think first of all, women need to trust their bodies, trust their feelings. And I think the Hear Her campaign, which is part of what we launched for Black Maternal Health Week, talks about that importance of, from a provider perspective, that we listen to the pregnant women, but we also need help to really help our pregnant women have an advocate to help express themselves when they go to the visit. What do they need to know at that visit? What should they, do they want to know? I always say, what is the reason you came here today? If I'm the provider, what brings you into the clinic today? And what do you want to get out of this encounter as the client? So that I can really, as the provider, really frame it around you, the client, and what your needs are.
Awesome. Are there any other questions from anybody in the group here in Zoom or on Facebook?
We don't have any on Facebook or in the chat.
Oh, Phil, it looks like you are on mute, sir.
Now, can you hear me?
I sure can.
I just had a question. The statistics, are we able to access those after we're off of our Zoom and our Facebook? To either keep those for ourselves, print those for ourselves, or forward those?
Yes, the
How do we do
presentation
that?
will be made available.
Okay. Thank you.
I am going to put two of my team members on the spot because I know they have done quite a bit of extensive research leading into this topic on behalf of the Winnebago County Action Team. I will start with, well, Elsie, one first. Thank you for asking the questions that you have asked and furthering our discussion. Elsie and Harlan on our team did quite a bit of research on our end. What else, based on the data that you guys have seen today, the most up-to-date numbers, what did you guys find shocking and what do you feel is most important for the public to know about this initiative?
Well, most of the things that were shown, we had knowledge of, basic knowledge. So that was not a shock. But what really puzzles me is, how do you educate these folks? How do you get the word out to them so that they can utilize or get access? The education part is what is the key piece, I think, that needs addressing.
Harlan.
Yes, first of all, is there a single consumer on this video? I don't think I see anyone who's a consumer. I know there was a person who is involved directly with this whole issue as a woman who may be or is pregnant or has a baby. And the idea in our marketing was to reach consumers. So we need to really reevaluate that.
Well, I believe in this space, Harlan. This is the Zoom link. The public is able to access the Zoom link, or they could be watching Facebook Live. So I'm not too sure what our attendees look
So
like.
later on, consumers may be watching this. Okay.
Well, we are Facebook Live right now, so we probably may have consumers watching.
Right. Several things have come out from the work that we've done in research that I'm hoping we will deal with in the future. One is that what we heard from Dr. Martell was about morbid obesity. Actually, recent research indicates that women who are just a little bit overweight are far more likely to have problems in their pregnancy. Another thing that I'm hoping that we will be able to deal with in future in our future presentation is around the tremendous value of doulas. And then the challenge of how do we reach every single woman who is, and child, who is pregnant, or so that we can actually get them involved with doulas, and how can we work that out from an economic perspective so that no one misses having a full-time doula if they don't have the financial ability to do that. Now that may already be in place, but I don't know one way or the other on that. Thirdly, there's a national program that I've just seen advertised on TV about a program that provides doulas who are 24/7 available. And if we were able to work out something with that company, with that organization, we would be able to also allow so that anyone who has a doula would be able to call a phone number even at 3 a.m. if they have an issue, and have someone who's happily willing to answer it. There's so much out there that's available in terms of what can be done to solve the problem. And my interest is to be solution focused. So this was valuable information for those of us who are professionals, but in terms of the general public, I don't think they're going to be as interested in this information, or they may already have it, but they're wanting to know what can really enhance the likelihood.
Let me kind of link back on that. So as we know, this was an introduction about why should this matter?
Mhm.
And I think we have to draw first attention to why should this matter to the general public? And you're right, we want to be solution focused over the next year. And I think the kickoff is different topics. Doula is one program that can look at it, but we call about birthing centers are another concept that are being out there, pregnancy-centered care. These are kinds of new, well, really old adaptations of new, kind of reframing it, but looking at the outcomes associated with that. We also need to make sure when you look at the bottom of that triangle, are our moms coming into their pregnancies at the best health that they can be? So when we look at those social determinants of health around that, what are we doing as a community to ensure that there's safe, stable housing for our families? What are we doing to ensure that there's no lead exposure so that even a pregnant mom, who's exposed to lead can pass that on? What are the job opportunities and childcare opportunities for our parents to have a living wage? We will also be engaging with that, support system is for that mom, whether it's, whether it's the father of the infant, whether it's another partner in the home, what is the extended family there to care for that infant and that mother? As a community, what policy level decisions can we, as you know, there are communities that have made home visiting for, not necessarily doula, but home visiting as a standard that every family has a home visitor. And then the home visitor, based on the needs of that particular family and what the family wants to receive care for, then develops that plan to move forward. And what a difference that might make, a kind of from beginning to end. So there's lots of work going on. In terms of, again, when we talk about obesity, I want to be clear, we're not talking about shaming people's body, or we're talking about our health risks. And again, we know that the individuals, what we're talking about is how can we improve people's health outcomes? I'm just as concerned about people's, we talk about their blood pressure coming into a pregnancy. Also their emotional health coming into a pregnancy. While we talked a lot today about the medical complications because they impact Black women more, we also know mental health is an extremely important concept as we come in. What is the framework and the mindset? Do we as a community value and respect pregnant women as individuals who are caring for our future? And the importance of that. Is it sufficient just to have a parking space closer that says for pregnant or breastfeeding moms? Or is it more a mindset of a community? Are we set for, when we see a pregnant woman, is it a smile? Is it a welcome? Do they feel that they are honored and valued in our community?
Thank you, Dr. Martell and Harlan. And then Harlan, you brought up a good point about doulas moving forward. I know within our team, you and Elsie had prepared an extensive list of different topics and things and suggested dates of doulas. And I'm pretty sure our next The next event in this series, I apologize for being tongue-tied, will be focused on doulas. We have reached out to Children's Home and 8. They have a doula program. And we've also been exploring other organizations that provide advocacy that is free of service as well. So yes, we will be tackling all of those, and we look forward, just as a partnership between the action team and the health department, to really tackle all of those subjects. I see another hand, Cornell.
Yes, I had a quick question just regarding the birth to 3 home visitor program. How often are the home visitors meeting with the families?
That depends on the program itself. Each program is guided by evidence-based models, and the models will dictate exactly when home visiting will occur. On average, they start out on a weekly basis, and maybe 60 to 90 minutes at a time per week. And after about a month or so, it will decrease to about twice a month or something like that. But it's usually at the very beginning, significant amount of time to begin with. Did that answer your question?
Yes, thank you.
Mm-hmm. I wanted to mention also, we were talking about doulas, but our home visiting staff from all of our 5 home visiting agencies, we had them to come up with topics that they wanted to hear. And it was interesting because one of the topics they chose, quite a few of them chose to hear more about the doula program. So at our last meeting that we had, we did have our doula agency that talk more about the doula program to give information, because I don't know if this was an area that their families were asking about, but our home visitors definitely wanted to know more about doulas and what they do. So we did have our doula agency come in and talk about how they care for the mom before, during, and after pregnancy. And it was very good, mothering the mother. So it was a very informative piece of information that was presented to them.
Thank you, Shireen. We have a comment from Facebook. I just want to acknowledge Miss Paula Stone Fitzpatrick. One, thank you for tuning in and taking the time to join us to talk about this important topic. But she shares that the numbers for no breastfeeding and cesarean births are surprising to me. I'm so glad that you all have these new programs in place. So thank you for your comments. We know it's an uphill battle, and we have a lot of work to do. And we look forward to partnering with you as a community member. So hopefully you can continue to join in and spread the word and help us further this initiative. Any other questions? I know it's over the lunch hour. Our hope was to keep the presentation somewhat short. Our goal moving forward is we really want to hear from more community members. We want to hear the stories, the comments, the feedback. And what we plan to do is keep track of this data and share it with healthcare professionals. Please note, on the back end, we are trying to connect with as many organizations, individuals in the community. We have partnerships with the health systems in place. They're on board. There will be future presentations by them as well. But ultimately, we want to get your information to those that need it and figure out how we can change the surface of our community. If there are no other questions, no other comments, we can wrap up today and conclude. Last minute questions, comments?
Just want to thank everyone for their attention and really getting the word out about what an important topic this is. It's been, we know it's a labor of, I'm going to say, love and commitment for all of us on this, but more importantly, so important for our community to understand the impact and that families are our infrastructure.
Okay. Thank you, Dr. Martell. Oh, we have one more question from Harlan before we wrap up. You are muted, sir.
I'm asking everyone, what can we do so that we will get more of the public, more of the consumers to really be interested in watching this show so that we'll be able to reach directly to them and also get them involved to helping each other. It's a challenge, but I think if we all put our ideas together, we may be able to do a good job of reaching way beyond just the professionals in the community and reaching the actual consumers.
Thank you, Harlan. That's a great question. Which leads me to, we plan on this being an ongoing series. It doesn't have an end date as of right now. And every fourth Thursday around 12:30 during the lunch hour, we plan to do a short presentation, whether it's initially being informative and getting feedback. So I feel like the first step in that is being consistency. We need to do our part to show the community that we are dedicated to this effort and this is important to us and that we're not just doing this to check a box. So I think with consistency, we will get the community's buy-in. I am grateful for the people who are on our Facebook Live today. I'm not in front of those numbers to see who all is tuned in. But I think with spreading the word, tagging us on social media, we have a social media page, Keeping Mothers and Babies Alive through the Winnebago County Health Department and Winnebago County Action Team. So it's just a matter of sharing the information and we all have that individual responsibility to do so and encouraging members of the community to tune in to our next one on May 26th at 12:30. And if you have suggestions and other things you want to hear, message us in the meantime. We're pretty accessible. All pages will be monitored in between time.
And Harlan, we are inviting, so if you're on a Facebook Live and you'd like to be one of our co-hosts for we are looking for our clients and our community members to kind of be co-host with us, to be the one that answers the tough questions of the speakers and the moderators about how we can do a better job.
Thank you. Well, with that being said, I thank everybody for tuning in and I look forward to next month. See you soon.
Thank you, everybody. It was very informative and very professionally done. Thank you so much.
Bye, everybody.
All right, we're off live.
Looks like we're still recording in this space. Did you want to stop recording as well?
Sure, I can stop the recording.